Allison.
Dive in.
Thanks to AEI for hosting and PBGH for the invitation. I'm really happy to be here today representing CalPERS. So for those of you who are not familiar with CalPERS, they are the largest non-federal purchaser of healthcare in the country. They, in 2016, spent about $8 billion on behalf of 1.5 active and retired California workers and their families. They have a similar cost and utilization pattern to the national trends. So about 67% of costs are incurred by 8.5% of the members, and 1 in 4 members has at least one chronic condition, resulting in about 50% of total spend, so similar to nationwide. So given that case mix and the level of spending that we're talking about, CalPERS has had a consistent goal of reducing our healthcare cost growth. And to support that goal has really been a leading innovator in the design and implementation of new health benefit purchasing innovations that have demonstrated both cost reduction and improved access and quality for our members. So they've developed several very highly successful health benefit initiatives to improve health outcomes and really lay the groundwork for different reforms, including some of the other panelists will talk about, including bundled payments, accountable care organizations, value-based purchasing, shared decision-making, intensive case management, and incentives for disease management. But these initiatives were all focused on insurers and providers, while the consumer really remained indifferent to price. So CalPERS chose to implement a consumer-focused reform that pursues those same core goals of improving value, not as a substitute for insurer and provider initiatives, but as a complement to those initiatives. So reference pricing for knee, hip, and joint replacement, which is one of CalPERS' more well-known initiatives and the one that I was asked to talk about today, has helped reduce our costs without a reduction in quality or patient satisfaction, as well as addressing the dramatic cost variation that we see in California among hospitals, which varies from about $15,000 to $110,000 per admission with no measurable quality or outcome difference. So just to level set, and referencing Ann Boynton, who used to run reference pricing and described this in Health Affairs, in reference pricing, the healthcare purchaser places a limit on what it will contribute towards payment for a particular procedure while assuring that the selected limit allows appropriate access for all the patients. It's typically the median or some midpoint of the distribution of prices in that local market. And then consumers who select a provider who charges less than the purchaser's limit gets the standard coverage with a minimal contribution, and a consumer that selects a provider that charges in excess of the limit pays that entire excess amount. And that excess payment that's made by the consumer does not count toward their deductible or their annual out-of-pocket limit. So these are really conceptualized as network exclusions, but a milder form of those inherent in narrow network benefit designs. So in other words, reference pricing offers full coverage at cost-effective providers and partial coverage at more expensive providers, whereas narrow network strategies really offer full coverage at some providers and no coverage at other providers. So how did CalPERS go about this? In 2011, for CalPERS' self-funded PPO plan, Anthem Blue Cross of California, which has about 220,000 basic plan subscribers, they established a threshold of $30,000 for routine single knee and hip joint replacement hospital stays. If the member doesn't elect a designated hospital and there are provider charges in excess of that threshold, the member pays the difference between the threshold and the hospital charges. So Anthem's 46 designated California hip and knee facilities assure adequate access and were selected after careful analysis of cost, member distribution, and geographic factors. They all performed at least 10 of the surgeries on CalPERS members and complied with the payment thresholds, and they're high-quality facilities in California. So these include University of California, San Francisco, Cedars-Sinai, and Loma Linda. And then in 2012, CalPERS began reference pricing for colonoscopy, cataract, and arthroscopy, where they faced similar variation for the price in those services, from about $1,000 to $6,500 for cataract removal, from $1,250 to $15,500 for arthroscopy of the knees. So for those services, they structured the reference pricing a little bit different. If the member goes to the member can go to any ambulatory surgical center or they receive $2,000 for cataract, $1,500 for a colonoscopy, and $6,000 for an arthroscopy performed in a hospital outpatient setting. So in other words, if you go to the HOPD, the reference price applies. In 2013, the average CalPERS price for a cataract procedure in a hospital outpatient setting was about $7,500, and in an ASC was about $2,250. A colonoscopy in the hospital outpatient setting was $2,500, and in the ASC was about $1,400. So what kind of results have we shown? Our results showed an increased use of the reference-based pricing facilities, which had good or better clinical quality and patient experience. The average hip and knee replacement price charge declined 26%, or over $9,000 per procedure. The hip and knee reference-based pricing program in total is credited with cumulative savings of $5.5 million over 2 years. For cataract and colonoscopy, we showed an increased use of ambulatory surgical centers from about 70% to 92%. Average cataract procedure price declined 16%, or over $500 per procedure. Average colonoscopy price charge declined by 20%, or $475 per procedure. So in total, the cataract and colonoscopy reference-based pricing program is credited with cumulative savings of $1.3 million and $7 million respectively over the first 2 years. And for knee or shoulder arthroscopy, prices fell about 17%. So while these are actual price reductions, not merely a slowdown in the rate of price growth, there's a difference in how these savings were achieved. For hip and knee replacement, that's really a hospital market story where they expanded the number of facilities from 46 in 2011 to 72 in 2015. For cataract and colonoscopy, that's a consumer story with an increased use in the lower cost, high volume facilities. So the prices in the HOPDs didn't change, but the savings came from the consumers going to the more cost-effective ASCs. Obviously, there are significant policy considerations that come with an initiative like this. Appropriately constructed programs have a number of consumer protections built in. For example, they have to permit exceptions based on clinical needs and geographic location of individual patients. In our program, people still have options of where to get their care and are able to get their care locally. We did an extensive amount of communicating with our members to ensure that they understood their options, which is critical. And CalPERS provides exceptions when a member lives more than 50 miles from a facility that offers the service below the limit price. It also exempts the patient if a patient's physician gives a clinical justification for using a high-priced facility or hospital setting. So another policy consideration, reference pricing can really only be done with shoppable procedures. Routine single hip and knee replacement surgeries are elective. That is, the patient can decide where, when, and how he or she wants the procedure to occur. Other shoppable services in healthcare could include scheduled hospital procedures, ambulatory surgical procedures, laboratory tests, imaging, and drugs. In fact, one study estimated that about 40% of healthcare spending is for services which patients could shop for. Also, policy developments have to be watched to ensure that barriers such as out-of-pocket limits that do not allow for reasonable consumer incentives with accompanying protections are not put into place for large self-insured employers. And reference pricing requires patients to have easy access to price and quality data, a level of transparency which is not yet commonplace. So finally, what is the applicability of reference pricing to a nationwide purchaser and or a public payer like Medicare? We only did this in California with California facilities and California-based members. For a nationwide employer or purchaser, there would be additional and likely challenging considerations. You'd have to identify an adequate number of reference pricing facilities to maintain access to local care, and consolidation may be an issue in some areas of the country. You have to maintain the contractual relationships. You have to determine whether the reference prices are set locally or regionally or nationally, et cetera. Also, to undertake reference pricing, cost sharing and network variations must be allowed within limits. So it's difficult to apply this to traditional Medicare where those things can't really vary. However, Medicare Advantage health plans, because they have the ability to impose differential cost sharing requirements and exclude providers altogether from their contractual networks, could use reference pricing. Also, pursuing reference pricing for prescription drugs in Medicare has been discussed. For example, the Part B demonstration this administration proposed but never finalized suggested that reference pricing could be examined during what they called phase 2. Under a proposal like this, Medicare would earmark therapeutically similar drugs and set a benchmark or reference price that it would pay for all the drugs in that category. It could be the amount the agency considers the most cost-effective in the group, or some other measure that serves to narrow the variation in what's paid for similar drugs. So bottom line, with adequate consumer protections, reference price can lower cost, address variation, and engage consumers while maintaining quality and patient experience. But it has some limitations in terms of applicability depending on the organization's flexibility and scope.